So thank you everybody again for your patience with all of the technical challenges, but I think we were able to get through it. We actually do have a number of questions, actually quite a bit of questions, so we'll try to get through them as much as possible. A lot of them were actually answered during the presentations, but I think Bree and I will just go through the list to make sure that there weren't any other questions. But if anybody in the audience would like to ask a question, you can feel free to either raise your hand if you'd like to say them over video, or you can put them in the chat and we'll make sure we get to those too. So if anybody attending live has questions, please feel free to either raise your virtual hand or type it in the chat. But let's start with some of the questions that came in prior, Bree.
Sure. So the first question was, my doctor has recommended that I get an oophorectomy. Should I wait until after the surgery to get pregnant? Should I even be considering a pregnancy? Doesn't that mean I have a high chance of recurrence? And I think she's probably asking because of a BRCA mutation, I would imagine. If anybody wants to take that question on.
I don't know the fertility implications of that, but for treatment, we would probably only offer that even for a BRCA patient who's high risk until they're done with childbearing. So I don't think we would do any surgical intervention about removing any ovaries until after that.
Yeah, and certainly, if anytime you remove an ovary, you're losing all those eggs. So we would always discuss it with the oncologist and see what the implications are, and can we get eggs quick enough or not. So it really would be a team discussion between the oncologist, ourselves, and the patient and their family.
Great, thank you. The next question is, if I had a triple negative breast cancer, does it put me in a higher risk of recurrence by getting pregnant?
We don't think so. Even the idea of having recurrence of breast cancer with pregnancy, it hasn't really been shown. That's why we think it's safe. So it shouldn't be either for triple negative breast cancer. It's not a hormone-driven cancer, so no. Although it is a more aggressive subtype of breast cancer and has a little bit different timeline as far as when we, worry about recurrences, but no, in general, there's no biology to suggest that.
And then someone asks, how long should I wait after my diagnosis and treatment to start getting pregnant?
I think so. We kind of covered that with the positive trial. So 18 months is at least, when they said you should be on the anti-hormone and then consider going off of it. So that's usually what I say in my practice. Although the retrospective study with those, 112,000 breast cancer patients, they did wait the full 5 years, or majority of them did in that retrospective analysis. So, but we'll find out with the prospective data when that clinical trial reads out whether or not 18 months is sufficient.
And the next one is, does a double mastectomy reduce recurrence risk from a pregnancy? I think a lot of these recurrence questions, I guess Dr. Fukui already kind of said that the pregnancy doesn't affect recurrence. It doesn't matter like what your situation might be, but if you kind of follow that 18 months guidelines, and I mean, maybe on the conservative side, the 5 years, then it doesn't, regardless of what your situation might be, affect the recurrence. What about, when should I resume tamoxifen after giving birth?
So it's not something you want to be taking while breastfeeding. So when you're done with that, it's perfectly fine to resume.
And then this question is, will I be refused or have a lower chance of being accepted for becoming an adoptive or foster parent because of my medical history?
Domestically, no. I actually have a client right now that has a history of cancer, and you do have to get a medical clearance done, but we're not doctors, so we leave the medical clearance up to their physicians. Internationally, it's a little bit different because some countries do have very strict parameters around the adoptive parent's health and whether or not their health will affect their ability to parent in the future. So if you are concerned about your medical history, I would maybe suggest looking into more domestic programs than international. But if you are set on international, I would just research which countries are a little bit more stringent about medical history of adoptive parents.
Yeah,
Okay.
I think also too
Oh,
that,
yeah, Mindy, please.
you know, like just in anything that you would do, you would always be planning ahead. So, you know, we've had people that we've asked to, you know, hey, listen, just to make sure that your child is cared for forever. Like, you know, they'll have the backup, you know, they'll have talked to family members, they'll have identified somebody too that would be willing to, you know, in the event that, you know, that life ends, not necessarily because of cancer, but just because, you know, then they'll go ahead and they'll, you know, also identify people that could assist in caring for and taking it from there, should that scenario ever happen. And I think it's been my experience too with the social workers from the state that in the same way that Shaylah just talked about, they'll ask the same things too.
Great, thank you so much. So what will happen if my cancer comes back while I'm pregnant? I think Dr. Fukui touched a little bit on that, but if you could kind of, what would like be the decisions that would need to be made?
Yeah, so actually had a few cases like that, and it depends on how aggressive the tumor is. So sometimes we have to start treatment right away, and that can affect the developing baby. And so there are some hard choices that might need to be made depending on that situation. If it is a little bit later in the pregnancy, we can often give treatments during that time safely. I did have to give chemotherapy when someone was in their second trimester, and that is something we can routinely do, and the babies are fine. So that, you know, comes up. So we can safely treat. One thing that we cannot do during pregnancy is radiation, but we can give chemotherapy. And then the endocrine therapy, of course, we cannot do until after someone is given birth.
And then someone asked, do I need to be married to adopt or foster? And then someone else had also asked, you know, if I'm single, can I pursue family building options, or do I need to have a partner to pursue this?
I would say, well, I have said to the people who came, I used to do home studies too for our company, and it hasn't been a requirement for us that, you know, like it's okay to be single and be a foster parent. It's okay to be single and be an adoptive parent, but there are agencies that will require it, just depending. So I'll let Shaylah address that too.
Yeah, some agencies do require people to be married. So you'll just have to, again, look into what the agency's requirements are. Again, internationally, there are some more strict guidelines just in general. Some agencies, I know there's one agency, I can't remember which one, requires you to have been married for a certain length of time before you apply. But like for a Kamakana program, for example, we have a couple of single applicants right now. So just have to do your due diligence to find out whether or not the agency that you're interested in does have that requirement. I will say, kind of touching back on what Mindy had already mentioned, when you are applying, if you are thinking about applying as a single applicant and you also have a medical history, you will, like Mindy mentioned, want to make sure that you do have support networks in case something unexpected were to occur.
Okay, great. So maybe this is not so much related to pregnancy since we already established the recurrence risk from a pregnancy, but in general, I guess, Dr. Fukui, are there any food, supplements, lifestyle factors to change to reduce the risk of recurrence in general, I guess?
Yeah, so there's a lot of literature looking at lifestyle interventions and helping to reduce the risk. There was a low-fat diet intervention because we know that being overweight can increase a woman's risk of recurrence. So there are studies looking at that as well as physical activity. And we have one that's ongoing in partnership with the eye care program at the Rehab Hospital of the Pacific and at the University of Hawaii Cancer Center doing some body composition analysis. I think stress is really important to also be aware of, that it can affect overall health, and that includes cancer as well. And then as far as other supplements, nothing was really panned out. And so we don't, besides the treatments that we'd recommend, we don't routinely recommend anything additional to that. And then of course, you know, to avoid excessive alcohol use and smoking.
Someone also asked, and I'm not sure if anyone can answer this fully, but are there breastfeeding options if they've had a double mastectomy?
I think donor milk, but I'm not sure if anybody else knows any more about that. I'm not sure.
Now we have had instances where we've had a gestational carrier who would pump and provide milk for others who, you know, if she wasn't needed to provide milk for the child that she had helped carry and deliver. So that's an option as well.
Will reconstructed breasts change with the pregnancy?
It depends on the reconstruction. If it's a full mastectomy, shouldn't, but you know, there can be changes underlying skin and a collagen, but that might not be the best. I'm not sure if there's a breast surgeon that might be able to answer that, but I haven't seen that. And I have a lady who's pregnant now after a triple negative breast cancer diagnosis, 2 years out. She actually had both breast and cervical. And she had bilateral mastectomies with reconstruction, and she's doing really great, and her implants look great. So I would say probably not.
Great, thank you. And we can also follow up with the breast surgeon as well to ask about that.
The next question is, how do we use frozen eggs and how much might it cost? Can I use frozen eggs while I'm on tamoxifen and Zoladex?
So I guess first of all, yeah, we would not want, you can't use the frozen eggs if you're being treated with any therapies at that time. As far as using frozen eggs, we basically need to thaw the eggs and fertilize the eggs, and then get the uterus ready for an embryo transfer. The cost it will vary depending on what needs to happen. As far as, you know, if we certainly will need to do ICSI, but depending on the number of eggs and if there's an issue with the sperm that we need to do anything else with it. In general, thawing eggs and fertilizing eggs and doing a transfer ends up being about $7,000 total for that process. and I didn't go into this earlier, but freezing eggs for patients who are doing fertility preservation, that's usually in the neighborhood of $12,000 to $15,000. However, for cancer patients, because we have grants and we work with some Lindy institutions, the cost is about half. It ends up being about $7,000 for a cancer patient who wants to freeze their eggs.
Thank you. Just a quick follow-up question. Is that a one-time cost, or are there ongoing costs to store them?
So there are costs associated with storing the eggs. We also work with a long-term storage facility on the mainland where the eggs can be shipped and stored. And I believe the yearly cost for freezing eggs there, it ends up being about $400 a year, as opposed to local storage is about double that.
And I think you had mentioned to me before that like oftentimes like insurance won't cover the preservation costs, but after cancer, if you have like a true diagnosis of infertility, sometimes insurances will cover. Does that sound right?
Yes, correct. There are instances where you can get some fertility treatment coverage if you meet criteria with the insurance. Notably, HMSA is probably the one that really has stepped up and done the most. Although none of them at this point cover fertility preservation for cancer patients, but hopefully in the near future that will happen.
Yeah, there were a number of questions regarding financial assistance and resources related to that. And I just wanted to let everybody know that I am working with someone from the SAM Fund that, and we might do a separate webinar or possibly Instagram Live or something on that topic. So I think that we covered all of the other questions during the presentation. Oh, I guess this is for Shaylah and Wendy. How many children are adopted through your programs each year?
So it's kind of like a two-part question. Through the Kamakana program, we only place a couple of, most of the children that are adopted to our Kamakana program are placed at birth. We only place a few infants each year. Nationally, like I said, we do write the home studies for quite a few clients that go through other agencies, and so those numbers vary. I guess it depends on whether you were thinking about placing through our agency or through another one.
Thank you. Mindy,
And for us, you know, with Wendy's, we keep a smaller caseload so I have a chance to build relationships, solid relationships with the kids. And so this is also, I don't think I said it earlier, but Wendy's is only an Oahu-based program. It's not a state-based program just yet. So usually I'm averaging somewhere between 12 to 15 is the hope that I'll be recruiting for every single year. And with a caseload of about 25, which means that the other half is the half that's been matched with a family, and now they're in that process, right? That 6-month process before the courts say, yes, we believe that this family would be in the best interest of this child. And so last year, we had 5 adoptions, anywhere from preschool age to a senior in high school, almost turning 18. And the year before, we also had 5. And that year we had several actually medically fragile children that were adopted. So it's a pretty amazing thing.
Thank you so much. So I know initially we were going to have tables in our prior platform, but since we're in the Zoom format now, we decided to kind of go into that time since we started late anyway for the technical glitches. But I just want to make sure that if anyone on the call that's attending live had questions, you're probably waiting to see what the other questions were to see if yours are answered. But I just wanted to give a moment if anybody on the call has any questions. Okay. Okay. Well, I want to thank all of the speakers for your time today. This has been so informative. Bree, did you have anything that you wanted to add?
I mean, I just want to say we're so lucky to have such great resources on the islands in general, and like that even for people on the outer islands, these resources are available too. So I'm really grateful you could be here and share some information with us today.
Yeah, and so I have everybody's slides that I'll be sharing. Give us a week or so to edit the video so that we can post them. We plan to do them in sections so that they're by topic. We also have a resources page that we'll be posting both on Bree's blog site as well as Breast Cancer Hawaii's website that will list all of the different resources that were shared today, as well as others that Bree and I have found useful. And I will also email everybody Jackie's contact information, since she graciously offered to speak to anybody that was interested in her story. And thank you again, Jackie, for sharing your story with us. Bree and I will be around for a few minutes if anybody wants to stay and chat, just talk about what you might be going through. Bree and I have our personal stories too, and we're very open to sharing if anybody wants to stay and just chat. So, but thank you everybody for taking your time here on a Thursday evening, and have a great rest of your week. Bye.